We already covered the penicillins, and now we're going to continue with the bacterial cell wall inhibitors. So remember we said that we have beta-lactams and we talked about their mechanism of action, and we already covered penicillins. Now we're going to talk about cephalosporins, monobactams, and carbapenem. They all have this beta-lactam ring. You see it here, 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 and here. And remember, we talked about monobactam when we were talking about penicillin allergy. We said that if we are allergic to penicillin, truly allergic to penicillin, there's a risk of having cross allergy with other beta-lactams, and hence we want to avoid beta-lactams. And monobactam probably not, and I said that it is a beta-lactam, but it only has the beta-lactam ring. It doesn't have an additional ring here like this and this and this, and hence there is no cross allergy with monobactam. Okay, so now let's talk about cephalosporins. Cephalosporins, again, they are beta-lactams. We have the beta-lactam ring, and whatever substitutions we have, we're going to have differences in pharmacokinetics and in the spectrum of activity. I don't want you to remember the names, but I want you to remember that every time you see something that is cefazolin, cefuroxime, cef something, please know that this is a cephalosporin. So as you can see here, we have several generations of cephalosporins. We have first, second, third, and fourth, and also we have the fifth generation that we will see in the next slide. Of course, I don't want you to memorize which cephalosporins are in which generation. If I ask you a question, I'm going to tell you, for example, a first generation cephalosporin, a second generation cephalosporin. Okay, so don't worry about that. Now, what are the differences? The differences are as such. Mainly, the first generation, they are good for gram-positive, strep and staph, for example. So if you have a patient coming for a skin infection, your patient presents with fever and redness on the hand because of a mosquito bite or whatever, then you can think of a staph aureus, for example, skin infection, and you may be able to treat with the first generation cephalosporin. Second generation, they are for gram-negative E. coli, Haemophilus influenza, and Bacteroides anaerobes. Careful, they are not as good for gram-positive. So, first are for gram-positive, second for gram-negative. Yani, if you have a patient who has a skin infection, you don't want to give a second generation cephalosporin. Don't say to yourself, first generation works and second are definitely stronger, so I'm going to give second generation. No. Second generation are different. They are good for gram-negatives and bacteroides, whereas first are for gram-positive. It's very important. Third generation, here they are good for everything. They're good for gram-positive, you see, staph, strep. They're good for gram-negative, and they are also good for Pseudomonas. See, this is another time we see Pseudomonas. We've seen Pseudomonas with fluoroquinolones. We've seen Pseudomonas with penicillins that are specific for Pseudomonas, and here we have Pseudomonas with the third generation cephalosporin. So we have some options. And finally, fourth, comparable to third generation, yani gram-positive, gram-negative, even Pseudomonas, but they are more resistant to some beta-lactamases. So a bacterium may have a beta-lactamase and be resistant to third generation cephalosporins. It may be sensitive to a fourth generation cephalosporin. And now we are super excited about the fifth generation cephalosporins such as ceftobiprole and ceftaroline, specifically because of coverage for MRSA. So we already know that for MRSA we can give vancomycin, and now we also know that we can give fifth generation cephalosporin. Another way to differentiate the several generations, so we have here first, second, third, and fourth. We said that the first generation are very good for gram-positive, not as good for gram-negative. In contrast, the second generation, not good for gram-positive, very good for gram-negative. Third generation, good for both. Fourth generation, good for both, even better here, and even better for Pseudomonas. Other things that I want to point out is resistance to beta-lactamase. The most resistant to beta-lactamases are the fourth generation, and the fifth generations are even better. Now, if we're dealing with meningitis, maybe I wouldn't give a first or second generation. I would start at least with a third generation and a fourth generation. And you probably heard of ceftriaxone before, and ceftriaxone is a third generation cephalosporin that we tend to give in cases of meningitis. So here comes the famous table, and I'm showing you here the cephalosporins, first, second, and third. And as you can see, first generation gram-positive, second generation gram-negative and anaerobes, remember, Bacteroides fragilis. And then third generation, a broader spectrum, both gram-positive, gram-negative, starting to have pseudomonal coverage also, not as good for anaerobes. And remember, all the beta-lactams we're talking about, no atypical coverage. So far, the only drug that covers atypical are the quinolones in the fourth generation, or maybe also the third generation. Not for your memory, I put two slides here, not for your memory, but I put them because you're going to see them. You're going to see ceftriaxone that I just mentioned, and some drugs are better for the blood-brain barrier, others are not. Some are metabolized, some are not. Just thinking for you, if you see them, you say to yourself, okay, I've seen those before. And also here, some PK and spectrum, some differences here and there, definitely not for your memory. I'm sure Dr. Matar talked about the extended spectrum beta-lactamases, or the ESBL. Already we discussed what the beta-lactamases are. We said that those cut the beta-lactam ring, and we said that we have some antimicrobial that are resistant to beta-lactamases, right? We saw this table together, and we said that the third generation are resistant to beta-lactamases, the fourth even more, the fifth even more. But they could be sensitive to beta-lactamases, and those are the extended spectrum. Okay, and in here we have cefotaxime, ceftriaxone, and ceftazidime. Those are third generation cephalosporin that are quote-unquote resistant to beta-lactamases, but not to ESBL. Now you would ask me, are fourth generation also resistant to, also affected? Maybe yes, maybe no. It depends on the literature. So let's focus only on the third generation, and that is cefotaxime, ceftriaxone, or ceftazidime. If a bacterium has an ESBL, it will be resistant to those three. So how do you treat? We can treat with polymyxin E, colistin, and that is a PO drug, which is good. So we can treat in the community. Colistin is an old drug that we haven't used for a while, but now it's coming back because of ESBL. Or if we are in the hospital, we can give carbapenem IV. Carbapenem is actually a beta-lactam, as you will see in a minute. So it is a beta-lactam, but it is resistant to this ESBL. Some adverse effects of cephalosporins. Obviously, you have the risk of hypersensitivity. The frequency ranges, and again, the range of frequency is that wide because it depends on what kind of a study we are talking about. Are we talking about looking for a skin rash only, or are we actually measuring antibodies, etc.? Okay, so all of this is about hypersensitivity. Similarly to penicillins, we may have hematologic reactions, neutropenia, thrombocytosis. We may have reduced platelet aggregation, similarly to penicillin. Always we may have GI side effects. We may have hepatitis, diarrhea, non-specific or Clostridium difficile related. This is the superinfection. Remember, superinfection can happen with any antimicrobial. It happens more with broad spectrum and combination, but can happen with any antimicrobial. Ceftriaxone specifically is associated with biliary sludge and hence the risk of cholecystitis. We may have nephrotoxicity, and phlebitis may happen. and that is when you give the drug by IV, you may have an inflammation of the vein, so one has to keep on checking the venous axis. Now let me talk about a specific gastrointestinal reaction, and let me mention alcohol a little bit. I'm sure you hear in the community that if a person is taking antimicrobial, better not to take alcohol. And you ask yourself why we don't take alcohol with antimicrobial. Well, there are many explanations, and again, it depends on what antimicrobial you're talking about. However, generally, as I said, most antimicrobials are associated with GI side effects, right? So if you are having GI side effects, diarrhea, nausea, vomiting, whatever, and you take alcohol, it's going to be even worse. So this is one of the reasons. 2. Some of the drugs, such as cephalosporins here, may lead to hepatotoxicity, and alcohol may lead to hepatotoxicity. So this is another reason why you don't want to take alcohol with the antimicrobial. And the third reason, that is not specific to all antimicrobials, it is specific to some, and to some cephalosporins actually. Some cephalosporins have an antabuse-like effect. I don't know if you remember it from my lecture in drug-drug interaction and pharmacogenetics, when I was talking about alcohol dehydrogenase and aldehyde dehydrogenase, and I talk about the antabuse. Well, here it's the same mechanism. Some cephalosporins have an antabuse-like effect, so you would be really bothered if you take the cephalosporin with alcohol. So I hope by now you understand why everyone says, okay, you're taking antimicrobial, don't take alcohol. We're done with cephalosporin, and now we're moving to the carbapenem. It's the one that I just mentioned. I said if we are dealing with an ESBL, a bacterium that is resistant to third generation cephalosporin, we said, how do we treat? We treat with colistin or imipenem. And I said imipenem is a beta-lactam, but it would be hopefully resistant to this ESBL. So here you go, carbapenem, imipenem. What am I putting a circle on? The beta-lactam. I think you know by now. And how does it work? I think you know by now. It inhibits the cell wall synthesis. How? It inhibits the transpeptidase enzyme. Halas, penicillin binding protein. It's very broad spectrum. It is gram positive, gram negative, anaerobes, covers really well. So what do we keep it for? Empiric treatment for serious hospital infections. A patient is coming, has an infection, we don't know what it is, we don't know what we're dealing with, we take culture, and we may start empirically with imipenem until we know what the infection is. It is resistant to most classic beta-lactamases, but we have resistance, and we now have bacteria that are developing carbapenemase, and those bacteria are even resistant to carbapenem, such as imipenem, and this is a big problem. We do have a post-antibiotic effect like penicillin, not only for gram-positive bacteria, but also for gram-negative, and this is cool. Side effects, nausea and vomiting, common. Seizure risk, mainly in seizure-prone patients. Cross-allergy with other beta-lactams, I believe now you understand it, and we also have increased bleeding tendency. Now, imipenem is excessively metabolized in the kidney, so if you look at the box of imipenem, actually you will see that imipenem comes in combination with cilastatin. What is cilastatin here for? It's here to inhibit the tubular dehydropeptidase 1, so that this enzyme does not inactivate imipenem. So we would have more imipenem being reabsorbed and active, whereas so that we have more effect of the drug. The second carbapenem is meropenem. Of course, similar action, almost similar spectrum of activity. What we like about it, it has a lesser potential for causing seizures, and here we don't really need cilastatin to inhibit the enzyme. So far the beta-lactams that we have covered are penicillin, cephalosporins, carbapenem. Now we're moving to monobactam. So monobactam or Aztreonam is a beta-lactam. We already know that there is no cross-allergenicity with penicillin. We said because it's only one beta-lactam. However, there might be a cross-allergy with ceftazidime. Okay, ceftazidime, what is it? Cef something. This is a cephalosporin. We may have cross-allergy with ceftazidime because of the structure. Now, it is gram-negative coverage only. And because of that, we call it the non-aminoglycoside aminoglycoside. We haven't talked about aminoglycosides yet. This is going to be the next VOP. But aminoglycosides are ribosome inhibitors, and they are for gram-negative only. So, similarly to aminoglycoside, Aztreonam is gram-negative only. This is why we call it the non-aminoglycoside aminoglycoside. And here comes the picture. So you see Aztreonam here, only gram-negative, and if you go down a little bit, aminoglycoside, only gram-negative. And I didn't show you this picture for imipenem only. You see, huge coverage, almost everything, but again, no atypical bacteria. How about vancomycin? Look well. Where is the beta-lactam ring? Can you see it? Well, guess what? There is no beta-lactam ring. Vancomycin is not a beta-lactam. Start looking. It is not a beta-lactam. We're done with the beta-lactams. Those three VOPs are for the cell wall inhibitors. We have the beta-lactams, and those were the penicillin, cephalosporin, carbapenem, and the monobactam. And then vancomycin and teicoplanin, they're not beta-lactams. They work on step number 2 in the cell wall synthesis. And this is the where they work. This is step number 2 of the cell wall synthesis. They inhibit the polymerization step and not the cross-linking. I'm not going to go over the mechanism of action in details, but I want to tell you that the D-alanine is also important for vancomycin and teicoplanin, those cell wall inhibitors. And one way of resistance is substitution of D-alanine by D-lactate. Vancomycin, so we use it. Let me start with this here. I already mentioned that it is used for MRSA and MRSE. I already mentioned that. Remember, we said that for MRSA and MRSE, our options are vancomycin, and our options are also 5th generation cephalosporins. So they are good for that, and they are only for gram-positive. But we don't give it for any gram-positive infection. We make sure that it is MRSA or MRSE. It is not active against gram-negative. No gram-negative at all. So people think, oh, vancomycin is a strong drug. It is for everything. No, it is not for everything. It is for gram-positive and MRSA specifically. What is good for everything? Maybe the 4th generation quinolones. Imipenem, we just talked about it, and meropenem are very broad spectrum but not for atypical. So don't be confused by the word strong antibiotic. Really know what you're talking about. So here you go. We talked about that already. Here we give it IV, obviously, because we are dealing with a serious infection. Now we can give vancomycin orally to treat Clostridium difficile colitis. We talked about Clostridium difficile colitis being a super infection, and as a side effect, if you want, for the use of antimicrobials, the patient presents with diarrhea, and it could be Clostridium difficile colitis. So one of the options is to treat vancomycin, but careful here, the treatment should be oral and not IV. So orally to treat Clostridium difficile. When given orally, it will stay there and treat it. Vancomycin has a poor distribution, it's excreted in the kidney, and it's also bactericidal. So similarly to beta-lactams, vancomycin is bactericidal. So far from all the antimicrobials that we have covered, only sulfonamides and trimethoprim are bacteriostatic. Quinolones are bactericidal, beta-lactams is bactericidal, and vancomycin is bactericidal. Toxicity, hypersensitivity. We may have skin rash, eosinophilia, drug fever, phlebitis. So we have to be careful when we use it in IV. A patient may have a red man syndrome, and that is the immediate flushing of the upper torso and the face. And this is because of immediate mast cell release if we give the IV really quickly, if we flush it. But now we don't do that. Now we give the IV slowly using a Baxter. We may have ototoxicity. This is why if we're giving vancomycin for a while, we take plasma concentration levels, we take peak levels. And that is, for example, if you give the dose now, about half an hour later, you take a plasma concentration. It's the peak level, and you want it to be below a certain amount. Otherwise, there's a risk of ototoxicity, and there's also a risk of nephrotoxicity. One has to be careful. Teicoplanin, similar structure and mechanism of action like vancomycin. We also have risk of skin rash and hypersensitivity. In addition, we have neutropenia. We have ototoxicity, but it is less than vancomycin. And here we go. I believe this is the last slide. As you can see, vancomycin here, gram-positive only, and although it is good for all staph and staph, we keep it really for the MRSA and the MRSE. Never forget that.